Hi, welcome everyone. Please stand by. We'll give it one more minute and we'll start talking about graduate medical electrician. So please stand by. Okay, I think we're good. Good afternoon, hello, good morning if you're watching this recording. My name is John McElligott, the Executive Director and CEO of the Maricopa County Medical Society. This is going to be a great discussion today about graduate medical education, why it matters to the community here in Arizona, and some things that we can do about it. I'm really thankful for everyone at the Flinn Foundation for hosting this. This series of talks that they put on a wide variety of topics that are relevant to public policy are incredibly helpful to discuss. And today we have some amazing speakers. Brian Powell of the Flinn Foundation is going to introduce them, but I wanted to thank them as well. Heather Carter, Dan Derksen, and Jason Bezozo. Thanks for your time. Thanks for your expertise. I wanted to briefly tell you about the Maricopa County Medical Society and why this matters to us. The longest standing organization like this in the state of Arizona, there's actually a connection to the Flinn Foundation, and Dr. Flinn, as a cardiologist back in the day, he and his wife Irene founded the organization, and he was a president of the medical society, helped to organize physicians to improve care for patients, which is something that we still do today. So the Maricopa County Medical Society, and if you want to go online, you can find out more information about us at mcmsonline.com. We're a physician-led organization. The mission is to promote excellence in the quality of care and the health of the community. And then we also represent and serve our members by acting as a strong collective physician voice. We've got a couple big priorities that we continue to work on, rebuilding the social fabric and camaraderie of the local medical community. We want physicians to make friends, to connect with one another for patient referrals, improvements in care, research, and just to help to retain and recruit the best physicians that we need here for a growing valley. Also increasing the membership, valued membership for the physicians who are involved. So practicing physicians can be members, so can medical students, and so can residents. And we get out the word to physicians in the medical community in multiple ways. We do weigh in on policy issues and advocate and lobby on their behalfs. We educate folks. In a big way we do that is through the Arizona Physician Magazine. I will hold up a recent issue, the spring 2023 issue that was mailed out to physicians. If you want to see the digital version, go to arizonaphysician.com. Try to keep it simple. Dr. Priya Radhakrishnan, who's the Chief Academic Officer at Honor Health, talks about what they're doing for GME programs. We also interviewed Dr. Jaya Raj from Creighton University, who talks about their program, as well as Dr. Michael White from Valleywise. And then you also get to hear directly from physicians in a section called What Arizona Docs Are Saying about their views on whether we need more diversity in GME programs, whether we need more residency slots in general. And the answer is yes, we do. And who's going to pay for them? You know, the federal government, the state government, local government, or private organizations as well. And then you get a bunch of quotes in there. So check out the Arizona Physician Magazine. It's a great copy. If you're into podcasts, we release about 1 or 2 episodes a month, and we've released an interview with Dr. Dean Lori Kemper of Midwestern University. That was back in March, it looks like, talking about GME. And more recently with Dean Guy Reed of the U of A College of Medicine, Phoenix, talking about GME programs. And I think Jason may touch on this later on. Their planned expansion for GME slots through competitive grant process with CMS at the federal level for their funding to expand the residency slots in the partnership with Banner Health for Arizona. So there's a lot going on. The reason why we care about all this is that we want more physicians to be trained in Arizona and staying in Arizona. Just today, I attended the Midwestern University Arizona College of Osteopathic Medicine's graduation ceremony. There was a friend of mine who graduated and earned his DO degree. He did not match with a program in Arizona. So I think they graduated maybe about 220 physicians. And Dean Kemper had mentioned that approximately 73 are staying here in Arizona. That's okay. I would like that number to be higher in the future. And so he will be going on to a psychiatry program in Las Vegas with UNLV. At some point, I want more people like that to be trained and staying here in Arizona so that as Heather and Dan, I think we'll talk about, more of those people would stay here in Arizona because they get jobs, they love the area, they fall in love. All those things happen in their lives that helps them to have a foothold here in Arizona. So again, lots to talk about. Really thankful this conversation is happening today. And it's my pleasure to introduce Mr. Brian Powell of the Flinn Foundation, who is also a guest author of an article that was published in the Arizona Physician magazine. So Brian, thank you so much for what you've done in using your skills as a former journalist and how you're helping to communicate the great messages and the activity that Flinn Foundation is doing. So I'll pass it over to you.
Thanks, John. Yes, I am Brian Powell, Communications Manager here at the Flinn Foundation, and I'll be the moderator today for this CivEx webinar on the important topic of graduate medical education. John is correct. I wrote an article just in the spring 2023 edition of Arizona Physician Magazine about this very topic and about funding and formulas and the current situation in Arizona. The Flinn Foundation has been interested in this topic for decades, dating back to our founding in 1965 by Dr. Robert Flinn, a cardiologist, and his wife, Irene. So it's something that, as an organization, we've paid very close attention to and supported through all these years. And, we continue to support medical schools here in Arizona, a lot of research grants. We administer Arizona's bioscience roadmap, which has kind of guided the growth and evolution of the bioscience ecosystem here for more than 2 decades. And with us today is Dr. Dan Derksen. He's the director of the Arizona Center for Rural Health at the University of Arizona. Former State Senator Heather Carter, she's the executive vice president of Greater Phoenix Leadership. And Jason Bezozo, he's the vice president of government relations at Banner Health. And before we move into our panel discussion, I'd like to turn it over to Dr. Derksen, who will provide an overview on this topic.
Great, thank you, Brian, and wonderful to be here with everyone. For those of you live with us, let me just get this pulled up so I can go through. What I wanted to do is give you a snapshot of graduate medical education, and without making any assumptions, for those of you who aren't in medical school or residency or practicing, we refer to undergraduate medical education as medical school or osteopathic school, the 4 years it really takes to earn that MD or DO degree. And then after that, there's a national match program and graduate medical education, residency training. And that's really the training you go through. It can be anywhere from 3 to 7 or more years to obtain board certification in the specialty of your choosing, whether that's a primary care specialty like the one I pursued in family medicine, or surgical specialties such as general surgery or neurosurgery, or a subspecialty in pediatric or medicine specialties like cardiology or pediatric specialties. So that's kind of the overview of some of the terms you might be hearing through our discussion today. One of the challenges and opportunities we have really in Arizona is that we've grown very rapidly over the last 20 to 30 years. Over the last 5 years, we've been a top 5 growing state, and Phoenix is vied, I think, with San Antonio for #1 in major city population growth. So that's put us in a position where today we're the 14th most populous state of the 50 states. And our largest population growth has really been in ages 65 and older. We have one of the fastest growing low-income elderly populations of the states in the United States. And as a result, this is true of several of the southwestern states that are quite large, not only in landmass, but in population growth. And we've really lagged in both the practicing physician, but also the residents in training, the graduate medical education full-time equivalents. And the two factors, in addition, the one I just mentioned in rapid population growth, but also in 1997 as part of the balanced budget agreement with Newt Gingrich and President Clinton, is that the number of subsidized slots to the Medicare, which is the largest subsidized federal funding of graduate medical education, was capped in 1997. And because we've grown so rapidly in Arizona, despite our 14th rank in population, we're 42nd, for example, in primary care physicians per 100,000. Arizona has about 80 per 100,000, the US 95. In total physicians, we rank 31st at 252 per 100,000 versus the United States at 287. And we're 37th in residency slots. So while we may have pretty close to what we need in undergraduate medical education and osteopathic and allopathic medical schools, a lot of our graduates, as you just heard a little anecdote about that earlier, a lot of our graduates from DO and MD schools have to go outside the state to pursue residency. And we should be, growing our residency full-time equivalents at the same rate to match our population growth. So if you look from the physician perspective, the largest shortage that we have is in primary care specialties. So general internal medicine, general pediatrics, family medicine, geriatrics is generally what's included in that category. And we're today, to eliminate the health professional shortage area designations that we have in primary care, we need about 667 total primary care physician full-time equivalents to eliminate our current shortages. And by 2030, not that far away, we'll be about 2,000 short of our primary care physician full-time equivalents. But we're short across the board, and it's not just in our more rural counties. We only have 15 counties. I think Coconino County is the second largest county in landmass of, I think there's one county in California that beats out Coconino in landmass. So these very large tracts of frontier and rural areas without a lot of health infrastructure. And this is a graphic representation of where we stand. We have about 28.5 residents per 100,000 population, graduate medical education full-time equivalents, compared to the United States overall, 43.8. To get to a 15 rank, which would be commensurate with where we are in population, we would need today over 1,100 new graduate medical education positions to be where we should be for our population. There's considerable federal investment in graduate medical education training. By my calculations, and I went through this extensively again this morning to update the numbers, there's about $25 billion in federal and a portion of that through the Medicaid GME is state or non-federal. The big chunk of that is through Medicare graduate medical education. That was capped. A number of states, including Arizona, that have residency programs are over the cap. And so often those hospital systems that are sponsoring entity for a residency program have to come up with the cost to pay the resident and their fringe and what it costs to educate them. But it's a considerable federal investment. There's been a number of studies done. I cited a couple of them in there, and this presentation will be made available to you all after our session today. But the Government Accountability Office did a report in 2021 that it found that less than 1% of residents trained at a rural hospital. So about 10% or more of the population lives in rural areas, but very little of the training is in the areas really of highest need. So this is part of the challenge. A huge amount of money being spent through Medicare and Medicaid, a little bit by the Veterans Administration, and a tiny little fragment from the Health Resources Service Administration on the discretionary side of the federal budget for things like teaching health centers, which got $155 million last year. So our state, thankfully, has no cap on Medicaid graduate medical education funding. However, you have to come up with a non-federal share. And what that means is that for every dollar that we would put in either as a state or a hospital to support a residency program, if you're going to get Medicaid dollars, we'd get $3 back in Medicaid to support that graduate medical education. You can see that strategy through these intergovernmental transfers and other mechanisms where the non-federal share is paid for to draw those federal dollars has really allowed us to grow, at least on the Medicaid GME side, to where it is today. And our state Medicaid program, the Arizona Healthcare Cost Containment System, has been, I think, very forward-thinking about how we go about expanding that. And the last slide or two I have here is really some of what I consider the best practices, some in our own state, but often in other states, of what we could do to improve our situation as far as the number of physicians and then those pathways into practice through our residency programs. One that I care deeply about, because this is one I helped draft when I worked for Senator Bingaman from New Mexico, is teaching health centers, which is in Title V of the Affordable Care Act. We tried to get this on the mandatory side with Medicare and Medicaid GME, but it's on the discretionary side. It's up for a continuation of that $155 million. We're hoping for more, and we're hoping for longer. But 75 to 80% of the graduates that go through a teaching health center program remain in primary care to practice and work in a health professional shortage area, medically underserved area, or medically underserved population. That's an extraordinary outcome, yet it's the least funded of the graduate medical education programs in this country. Another one that I'm quite interested in that Senator Carter proposed some years ago, we didn't quite make it all the way through, but a tax credit for health providers that practice in health professional shortage areas in our state. I would add what Colorado did, which I think is quite clever, which is add a precepting requirement. We know that when we train our medical students and residents, for example, in a rural or urban underserved area, they're more likely to go into practice there. But especially if we recruit from those communities, oftentimes those folks that have connections to rural or urban underserved communities will go back into practice there when they finish. And I think we could draw on Colorado's example, perhaps for the next legislative session. And then what happened just this last session is really using graduate medical education dollars from a state appropriation and then putting that through our Area Health Education Center program to really help community health centers, Indian Health Service, and tribal-run clinics and hospitals start up primary care residencies in these areas of high need. And this is just our new map for the Area Health Education Center. We're one of 56 AHEC programs in the country, and we have 6 Area Health Education Center regional centers in the state, including the most recent one that was just executed 2 weeks ago, which is with the Center for Excellence in Rural Education, which will be kind of that those counties in Gila and Graham and Greenlee, and we're very excited about that. And the other newest one is our American Indian Health AHEC Regional Center that we just finished the agreement on after state legislation that Heather Carter first introduced some years ago to create the American Indian Health Tribal AHEC. And we're very excited about that because we really know that we need to get more health providers, nurses, physicians, and other health providers in these areas of high need. I look at our training milieu to expand these types of things, including graduate medical education, as our rural health safety net, but also this covers our urban underserved because both Pima County and Maricopa County, which tends to be more metropolitan population, also has very large rural areas and often very large urban underserved populations. So the core groups in that are the 17 critical access hospitals. These are federal designations, our 45 rural health clinics that are often affiliated with critical access hospitals, and then our 23 community health center systems that serve in over 200 federally qualified health center sites. And then in addition, the ones I mentioned, the 16 Indian Health Service hospitals and clinics and the 31 tribal operated, the self-determination sites around our state. So that comprises the kind of overview in graduate medical education. I know I talk kind of fast, but we have some wonderful panelists to share their insight, and I will make this available for you if you want to look into more detail or do some of the look at where some of the data and information came from. So thank you.
Thank you, Dr. Derksen. It's a great overview of the subject here in Arizona. You kind of alluded to, a signing of a bill in the 1990s. And I was going to have Jason kind of weigh in on what exactly was that bill and how has that hampered kind of the fast growing states such as Arizona, which has kind of helped to put us in the position we're at now, trying to play catch up.
That was a great presentation, Dr. Derksen. Thank you. I'm always learning, and Dr. Derksen's a wealth of knowledge. So I'll start off with, why are we talking about this issue? And access to healthcare is really important because poor access to healthcare leads to poor healthcare outcomes. It leads to an increase in morbidity and mortality rates. And so the more access we have to healthcare, the better off all of our citizens in the state are in terms of their overall health. And so that's the fundamental importance of this. Going back to the Balanced Budget Act that Dr. Derksen talked about in his presentation, before 1997, Medicare actually paid hospitals for residents, and it was an open-ended financing system. And then there was a consensus in the medical education, the graduate medical education community, that the trajectory of the country was that we were going to have too many physicians, an oversupply of physicians. And so Congress stepped in 97 and basically capped the Medicare financing system at where the programs were in 1996. And that cap has not been lifted. So for hospitals that were in the physician teaching business at the time have been living under those caps with respect to Medicare funding, the only other opportunities to grow their program would be through Medicaid financing or hospital financing, unless there's some other governmental source. So that's the system we've been operating in. It's going back to now 1997. I should say that the cap actually only applies though to those hospitals that had teaching programs back then. So if another hospital wants to start to do physician teaching and begin residency programs, they would have 5 years under which to grow their programs. And then at the 5th year, Medicare would put a cap at where those programs are based on the size of that 5th year. So new hospitals that don't have teaching programs could access Medicare funding today. But those caps have basically been a barrier to growth when it comes to physician training programs.
Right. And is there even any realistic chance of that changing? Because the states that are kind of slow growing or even losing population the last from 25 years ago, they're really benefiting as the states that were, Arizona had 3 million fewer residents back then. Is there even any chance politically of this ever coming up again?
Yeah, I think back in my own life, I came here in the early 90s, and the state's basically grown more than double the size in population. And on a per capita basis, our residency programs are roughly the same as where they were. So that's over the course of 30 years now. So we've been barely keeping up with the extraordinary growth that we've had. So for the last several years, members of Congress have introduced legislation to try to increase the number of residency slots that would get funded under Medicare. This year, there's a measure in the House, there's a measure in the Senate that are identical measures. They're called the Resident Physician Shortage Reduction Act of 2023. There was the same act in 2022. The same act was introduced in 2021, and you get the picture. I don't see a CBO score, which is the Congressional Budget Office. I can only imagine that what the bill specifically would phase in an increase of 14,000 slots over 7 years in this country. I imagine that it would add a few $1 billion of cost to the U.S. budget. The problem I see with this and the challenge is not the issue itself. It's going to be more of a financing issue. You can see right now, Congress is voting on a debt ceiling increase just so that we can continue to borrow to cover the federal government and all of the bills that it has to pay. We're running now a $31 trillion debt in this country. We have about a $1.5 trillion deficit in our current budget year. And so we continue to add to that debt. And so it just creates a challenge whenever you're trying to get some additional funding from the federal government. You have to look at the context of what does that mean for the overall budget and the debt picture. And I just think that that's the current challenge. So I'm not hopeful that we're going to have a federal solution in the near future to this. I do think we're going to have to figure this out through state solutions with our Medicaid partners and probably governmental partners.
And we have had some wins here at the state level. Heather, would you like to talk about your bill from a few years ago? And then we'll kind of talk a little bit more about the one that just passed this session as well. But kind of, we didn't have any state funding for many years, and then the bill was introduced a few years ago. Can you describe kind of what was in that bill and how you were able to get support for that?
Absolutely. Well, thank you. And it is just a privilege and honor to be on this panel today. It's probably one of, I think, the most interesting and fascinating topics that if we tackle this as policymakers, we can really change the lives of Arizonans and really provide the care that they need to be successful. So I had the great pleasure of serving in the Arizona legislature for 10 years. 6 of those years, or 8 of those years, I guess 6 of those years, I served as the House Health Chairwoman and Vice Chair the other 2 years, 2 in the Senate, 2 in the House. When I transitioned over to the Senate, I really started to think, what are the big challenges that we face in Arizona? And when I was first elected in 2010, started serving in 2011, I had stakeholders bring this issue of graduate medical education to my attention. And as somebody who didn't have a background necessarily in healthcare, my joke is I'm technically a doctor. I have an EDD in education, and I served for 2 years as a pharmaceutical sales rep. But we're a citizen legislature, so everybody brings their own unique skills, talents, and abilities and experiences to the legislature as they serve. So most of the legislature had no idea what graduate medical education even was. So when I first started really building my knowledge in this sector, graduate medical education was consistently the sort of pinnacle issue that we needed to address. That was in 2011. When I was elected to the Senate in 2018, we still had not even seen a bill to address this issue. We had never discussed it in appropriations. I also learned very quickly, if you want to get anything done, you need to serve on appropriations, because 9 times out of 10, you have to fund the policies that we're looking to advance. And this is obviously true in graduate medical education. So in 2018, with Dr. Derksen's help and advice and data from the Center for Rural Health, we were able to lay out the information that you saw here in real time today and say, if we could add additional dollars in graduate medical education, this is what we believe we can do to increase the number of physicians in Arizona and address our physician shortage. So I worked with stakeholders. Jason, if you remember, I called everybody into that big room over there in the Senate, and I said, we're going to tackle this issue. 8 years into my service, we're going to finally run a bill. So we swung for the fence. I think the bill, the original price tag, Dr. Derksen, was $54 million, if I remember right. And everybody thought I was crazy for running such a big price tag for a bill at that period of time. But what I wanted to highlight to our lawmakers is the state used to be in the business of funding graduate medical education. But prior to my election, when we had the Great Recession in 2010, that 2010 budget cut our state funding. We basically got out of the business of funding graduate medical education from the state general fund. So if you look at the trajectory of our revenue increases from 2011 to 2018, we had over $1 billion surplus. I said, if we don't get back in the business of funding from the state general fund, graduate medical education at this point in time, we're never going to get back in the business. So we ran a bill and we built a very broad stakeholder coalition to come together and share stories across Arizona about the impact of wait time to see a physician, whether it be a primary care physician or a specialist, and really tracked those stories legislative district by legislative district by legislative district. And you saw on the data that Dr. Derksen shared, we mapped it out across the entire state of Arizona. So when that bill was up for a hearing in the Appropriations Committee in the Senate, we had people driving from around the state in to testify and really share specifics on the challenges that they face in recruiting and then retaining physicians in Arizona and what that means for the patients. I really want to share this story, and if you ever are morbidly interested in watching a committee hearing, this is a case test of a perfect committee hearing of having people show up and testify on a bill. After each person testified on a bill and we voted on the bill, I think every single member of the committee shared a personal story of their own challenges of either seeing, trying to get in to see a primary care doctor, trying to get in to see a practitioner. We heard stories from somebody in Scottsdale who couldn't see a specialist, to somebody in Yuma who talked about the hours and hours of wait in the emergency room. And what happened was people started to really get interested in this issue. And it's an issue that they could then bring back to their communities and say, this is the way that I'm moving the needle to address the challenges we face. So we took a really, really complicated and not issue like graduate medical education that the majority of people had no idea what that even is, translated it through data and personal stories to show lawmakers how they can really make a difference in their communities. I am happy to report after that year, after that bill passed out of the Senate appropriations, it passed with incredible support on the floor, went over to the House. We had the same exact experience in the House appropriations. And if you ever watch the appropriations committees, that rarely happens. And of course, it came down to the 11th hour, and what finally made it over to the finish line was less than what we had advanced, but I think we still got close to $20 million over a series of 3 years. And now we're seeing the benefits of that investment as displayed in the data that Dr. Derksen showed at the beginning. So it was a real, I think, textbook example of what you can do when you address a real problem, use data, connect it to people across Arizona by community, make the investment, track the data, and show the improvement. So happy to answer any questions about that, but it's probably one of the highlights of my 10 years at the Capitol, being able to advance this and get the state back in the business of funding graduate medical education.
And Dr. Derksen, there was some success this past session as well that you mentioned. Can you describe a little bit more in detail about what was passed and how that will impact some training at either the community health centers or other places that will help the rural areas specifically?
Yeah, Jennifer Burns at the Arizona Alliance for Community Health Centers and that organization, which is Arizona's primary care association, but also houses our Central Arizona Area Health Education Center, Regional Center, shepherded that through the process. And, Heather sharing some of the inside story of how that works and the storytelling and the data to inform policy deliberations, I think, is really important. But the storytelling of individuals and how this affects them, how it affects their families. Maybe they have some legislators that didn't, had a person who didn't get into nursing school or medical school or into residency after accumulating a lot of debt and not matching in a residency program because there's just not enough slots in our state. Those things really make a huge difference in carrying it across the finish line. And I gotta say the broad bipartisan support and the sense of this is something we have something to show for. So it culminated. I always hope for a recurring appropriation. This year there weren't a whole heck of a lot of those, even though we're in a pretty good fiscal position to do so. We did get a $5 million appropriation to work through the Area Health Education Center system and our 6 AHEC regional centers to do this. And one anecdote, since Heather got me started on this, is a story. So I'm sitting in Heather's office, and we're conspiring on this big bill, this big expensive bill that neither one of us, I thought, had a chance in hell of passing. But anyway, we're doing that, and Kim Russell walks in, and Kim said, we have this idea. We ought to start a tribal AHEC. And Heather looks at me, what do you think, Dan? I said, I think it's a terrific idea. It took 3 sessions to get that done. By that time, Heather unfortunately wasn't in the legislature, but it made it through, signed by Governor Ducey, and then we just executed that contract and agreement for the American Indian Health AHEC Regional Center in September. So we're so happy. There's 22 federally recognized tribes, and if you look at the tribal reservation area, it's a significant chunk of our landmass in Arizona. And if you look at some of the health profession shortage area scores, those are some of the most underserved sites in the state. And we saw during the pandemic what happens when you don't have access to nurses and physicians, or one of them, God forbid, dies or becomes ill and can't work anymore. So for so many reasons, we have to address this issue. There are very fundamental things that we can do, and we can certainly draw on examples from other states on how to go about doing this. And I sure hope that the folks on this call will join this effort to really address this, because we're going to have to keep after it for a number of years. I think we're in a good position to do it. The window of opportunity is open for our state. I think a lot of the effort that's going to happen to be successful is going to be in our state and our collaborative effort between stakeholders.
And a lot of the training of physicians in residencies and fellowship happens at hospitals, but Arizona also allows that at the community health center level. And how is that beneficial to the rural areas, and are people who attend or train at the community health centers, are they more likely to stay in that region?
Yeah, we know from the data, from the teaching health center data, for example, that when you train people in communities of need, they're far more likely to stay there. When we did this in New Mexico some years ago, that was the basis for Title V of the Affordable Care Act and the teaching health centers, was that we found that 75% of the graduates from those programs that train in community-based settings, whether that was an Indian Health Service site or tribal operated site or a community health center, federally qualified health center, 75% remained in a health professional shortage area to practice. Almost all of them stayed in the state to practice. We can duplicate that at the national level, that teaching health center provision, even though it's way underfunded, $155 million compared to $25 billion in graduate medical education. That $155 million, the return on that investment is 80% of the folks who train in those centers work and stay in primary care, and they work in health professional shortage areas. So the data is there, it's compelling, and it's incumbent upon us to make sure that people understand that, and this again is very bipartisan, because you have our representatives and our senators from rural areas and represent large areas of the state. This is a win for them. It shows their constituents that we're serious about really addressing some of these issues. And many of them, in Phoenix and Tucson, try to make an appointment with a primary care physician. It took me 3 months to get into one of my own, and he was a classmate I went to medical school with. So all of us have our own stories. So, but we can do this. This is something well within our reach.
Right. And I mean, there is data out there showing if you attend medical school in Arizona and you are placed here for residency, there's a 75% chance you'll end up practicing here. So, I mean, there is data on why having a resident, enough slots for residents actually does turn into having people already practice here. Heather,
Brian, if I may
yeah.
add on to that, that you spelled that out absolutely perfectly. So taking that kind of on the inverse, we are preparing in our public institutions and our private institutions the next generation of physicians, and we have to release them to other states to do their graduate medical education, and it's near impossible to recruit them back. So, as we talked about, Dan, Dr. Derksen said at the beginning, we have, relatively speaking, enough spots. I'd always like to see more spots. Students that don't get into medical school would like to see more spots. Obviously, but compared to where we were, we have more spots. That was also part of the legislation that we ran related to graduate medical education, of which then the University of Arizona created the primary care scholarship program that says, if you agree to practice in Arizona, once you've completed your graduate medical education, basically you will not be charged tuition. That's a game changer. And Dr. Derksen, maybe you want to talk a little bit about that. But this piece about the graduate medical education, if there's not enough spots here for them to do their residency, they have to leave the state. Now, maybe if they go to a state that's similar to Arizona, like a Nevada or New Mexico that's close by, maybe you can get them back if it's just right over the state line. But otherwise, you're starting your practice where you build, where you do your training. And so it is almost as if, uprooting and starting a business in a whole nother state to get them back to Arizona is really challenging.
Yeah, the scholarship program has been incredibly powerful and popular. We have about 100 scholarships, so tuition and fees. And it's for each year that you receive that scholarship, a year is expected in return to coming to Arizona, back to Arizona and practicing in one of our many health professional shortage areas. There's health professional shortage area designated sites in each one of our counties. There's a large number in urban underserved areas of, for example, Phoenix and Tucson and Flagstaff. So there's plenty of spots to come back to and work. We're just now, because it's a long pathway into practice. So you go to medical or osteopathic school 4 years, 3 to 7 years of residency, coming back then to practice. We're just starting to see those folks that receive the scholarships come back, and that's really gratifying. And we're trying to capture some of the stories from how much that meant to individuals, because this is also a recruiting tool to get the best and brightest from Arizona to stay in Arizona for their residency program in their medical school, and not osteopathic school yet, but medical school at College of Medicine, Phoenix and Tucson. Come back for residency and then go into practice in one of our health professional shortage areas. So those stories, I think, will help persuade perhaps reluctant legislators and other policymakers that this is well worth the investment, and it makes sense. For community-based sites, which is, we need to balance the wonderful education that can happen in our two largest graduate medical education areas in Phoenix and Tucson. We need to balance that with community-based experiential training in rural and urban underserved areas. And that's the challenge. We have to train enough, but we also have to make sure that the incentives are aligned and the supports are aligned to distribute those graduates into areas of need. And we find that when we graduate folks from these programs, that they become our best field faculty, our best preceptors, our most inspiring field faculty. And it keeps them there, but they're also looking at it from the very selfish perspective of, I want to make sure we have enough providers here, because if I had to be on every other night, we've seen this in some of the maternity care areas, we lose people if they're on every other night or on every night because they're the only general surgeon in town or the only OB-GYN in town. So we've defined primary care very broadly by the highest needs areas that serve the largest geographic area that we can. So these are, things that where the incentives are aligned both for the folks who help train our health professions graduates, but also for the sites that would really like a chance at recruiting them for these unfilled positions that they have.
Thank you. And a lot of the training does happen at hospitals. I'm going to turn this over to Jason to kind of talk about Banner Health's major role in this state in training maybe close to half or about half of all residents. And, we've seen, Arizona's gone from 1 medical school to 6 medical schools in less than 30 years. And due to some creative ways of tapping into Medicaid funding, we have been able to increase slots. I mean, we're still well behind, as we've heard here, but up, from about 1,200 in 2007 to almost 2,200 last year. But I'd like to hear a little bit about, for people training at hospitals, what does Banner do, and how does Banner kind of approach the importance of this topic?
So today we have about a little bit less than half the residents in the state at Banner's 3 academic medical centers. This is, with our partnership, which is an honor through the University of Arizona College of Medicine in Phoenix and College of Medicine in Tucson. So we do a little bit less than half. Banner is a nonprofit. We're a community-based organization. Yeah, we're a largest provider in the state, largest private employer. But we look at this as part of our community mission to the state, to train the future workforce of Arizona. And so this is an important part of our organization. And it's something that we want to continue to grow. As you heard Dr. Derksen and his team at the Rural Health Office, their calculation is that just to get us to where we need to be on a per capita basis, we need about another 1,100 or so residents in the state. So to try to keep pace with that, we're all going to have to expand. It's not one organization, it's all organizations, and it's not just hospitals, but it's other community-based providers. So yeah, this is an important part of what we do.
And University of Arizona College of Medicine Phoenix announced just last month that they're going to compete for some newly available federal funding, hoping to add a little more than 300 new residency slots here, with some new programs. And if they are successful in obtaining this funding, I mean, that will definitely help. And I don't know, Dan or Jason, if you're interested in whoever may know more a little bit about kind of what U of A hopes to accomplish here.
I could try to cover that a bit, if that's okay.
Yeah.
So I'll focus less on the actual numbers, but yeah, we're trying to work again closely aligned with the University of Arizona on this. Focus less on the number, but overall we do want to grow our residency programs. We want to bring in more of the hospitals that are part of our system that aren't today teaching hospitals, because they have the opportunity to participate in the Medicare financing system as well as Medicaid financing system. So hopefully we will begin to phase in, hopefully over the next year or so, new residency programs focused around family medicine, rural family medicine as well, working in partnership with other community-based providers around the state, both in rural communities, IHS facilities, where, to help try to start to balance out that imbalance in terms of residency programs that we have today. So that's what we're trying to work for. We still have a lot of work to do to build this out. But again, if we were able to bring in a couple of hundred or maybe a few hundred residents, that still is a small part of the total need that we have. So, we're not in this alone, and we're going to need other stakeholders to grow their programs as well.
Dr. Derksen, anything to add to that about this kind of new announcement to go after this new funding?
Well, yeah, I think there's a lot to sort out in the next few days of how much discretionary funding there's going to be and who's on the hit list. It's a little scary right now because you had to deal some things and all that, but it's always the discretionary side of the budget, and we cannot depend on that. We're going to have to work really hard on the mandatory side of the funding too. And who says that it's only Medicare and Medicaid, the VA, and then a tiny little portion from the Health Resources Service Administration? They're the only ones who should, kind of be chipping in for this. This is something that benefits private health insurers. It benefits systems and others. So this is kind of a shared burden that this should be more equally distributed. I'm concerned, though, that if we continue on the same path that we've been doing, we do need to grow our residency slots in Phoenix and Tucson and some of our larger areas. But we really need to focus, and as far as the financial subsidies, we have to align that with the areas of need if we're ever going to address them. And I don't think we should do this by piecemeal alteration. I think this needs to be a bold thing, like what Senator Carter tried to outline. It kind of, raised a lot of eyebrows. So we got halfway there then, but we have some opportunities now. The window of opportunity is open for us. We're looking at, I think, a federal contingent that would love to support this because it does have broad bipartisan support. A lot of this is rural. That tends to be more conservative in rural areas. But I think the economic return on investment, it's estimated that for one family physician that goes into a rural community, it can generate as many as 20 jobs. That might be the nursing home, might be the pharmacy, it might be home and community-based services, it might be, any number of things. But we have to invest in that if we expect to grow our economic infrastructure in Arizona. And I know that has particular bipartisan support in the legislative makeup. We had a challenge this year. Half of our legislators were new. And so you go through a process of educating people, and Heather mentioned about this kind of very wonky kind of things around graduate medical education. What's that? What's undergraduate medical education? You have to go through the terminology again and get people. And then once they get it and they hear the stories from their own constituents, they're very supportive. So I think there's some real opportunities for us. There's a number of examples that we can draw on. We don't have to, come up with all our own ideas, although I think we've led the country in a number of them. For example, we're one of 56 AHEC programs in the country, Area Health Education Center programs. Of those 56 programs, we do 12% of the community-based experiential training and clinical rotations in the country. So we do this well in Arizona, probably better than most, maybe not quite as well as North Carolina, which is kind of the model everyone draws on for Area Health Education Center that's decentralized. But with the help of our policymakers, both at the institutional level, places like Banner that's already carrying about half the workload for residency education, but broaden that. I think we need broader shoulders on that. And then our policymakers, I think, stand at the ready to invest in things that really show that return on that economic investment.
Yeah, Senator Carter, I was going to ask you, as a representative of Greater Phoenix leadership, how do you see this topic being important, economically or, for the state's economy, just kind of quality of life in general? We've talked about the importance of being able to see a primary care physician or to be able to get into a specialist, but even, from the less health related, just from an economic standpoint, how important is it to have, more residents training and then more physicians practicing here?
Well, from an economic standpoint, as you just heard kind of explained by the data, this is a no-brainer. There are very few policy and or investments that you can, with clear, historically based confidence, map out what the economic impact will be for that policy. So when you're looking at improving the lives of all Arizona, and if you're looking at really providing an equity in terms of being able to access primary care specialists, healthcare in general, this is a no-brainer. So as the Executive Vice President for Greater Phoenix Leadership, I can tell you that the CEOs of the region understand the importance that the healthcare system plays in Arizona. It's an economic engine for many of our communities and for the state of Arizona. So just from an economic perspective, this makes absolutely perfect sense. We have weighed in on a number of bills to look at increasing the workforce in the healthcare space across all disciplines. And when it comes to physicians, that is something I think that when you look at it from a problem solution, graduate medical education is something that is, I don't want to say it's quick and easy, but it's quantifiable. There's a proven concept in place. We need to increase our graduate medical education spots. So this is something that the business community is strongly supported. I know that both chambers, the Arizona Chamber, the Greater Phoenix Chamber has supported this consistently. There really isn't anybody in opposition to it. Sometimes we can argue maybe over like how the money is spent. You know, we can have a conversation over what the split versus urban, rural, underserved populations, geographical distributions, primary care versus specialists. We can have a policy debate around the details, but Dr. Derksen and Jason, I don't know of anybody that actually straight out opposed doing this. And in my 10 years, that's hard to say about anything in healthcare. Did anybody oppose this?
I think the one thing that people would say is that oftentimes we focus too much on the physician side. I hear this a lot, as a physician, that we need to include other primary care areas, physician assistant. There was 1,000 applicants for 50 PA positions in the PA program and at NAU. And on the nurse practitioner side, the family nurse practitioner side, we just started this spring a new midwife program, which I'm really very excited about because we didn't have a midwife program for many, many years here. And this is just starting it back up. And if you talk about, 2 entire counties without labor and delivery services, and, the United States being like 37th of the developed countries in maternity, care outcomes, we should be doing better for the investment we make. And Arizona is worse than the national average. And then if you look at rural, it's even worse. So on maternity care, making sure we have prenatal care, labor and delivery, postpartum care, that is going to take some doing to address. And in Arizona, that is one of the largest areas where we could show dramatic improvement very quickly.
Dr. Derksen, I know there's one random fun fact. I hate to put you on the spot here, but a woman who is pregnant that lives in the east side of Arizona has to drive how many hours to see an OBGYN? What is it? It's like 6 hours and then
it can be very long distances. And then if you've already had a baby and you go into labor, you may not have enough time to drive, an hour or to 2 hours or longer to get to a place that will do deliveries. We're very concerned about that in some of our counties that share a border with Mexico, where they've lost some of their labor and delivery capacity. So those kind of outcomes should drive really our policy interventions around our health workforce. I know we're getting at the end. We're not already at the end of time. So.
No, I was going to say we're going to have to wrap up here, but thank you to all 3 of you for a great discussion, to the Maricopa County Medical Society for their partnership in this event, and for everyone joining us. This is a topic that it impacts all of us at some level. So it's very important, and thank you for tuning in. And we will be sending out a recording of this webinar with Dr. Derksen's slides, and they'll also be posted on the azcivicleadership.org. And thank you guys very much. And stay tuned for details about the next CivEx, which will be in late June. Thank you.
Thank you.
Thank you all.